Good morning, everybody. Um, what a pleasure this morning to be having Dr. Victor Santana as our grand round speaker. Um, Victor is assistant professor in both the Department of Family Medicine and the Department of Medical Education at Mount Sinai, and medical director of the Care Found Here program at the Institute for Family Health. He's also the founding director of Mount Sinai's Primary Care Scholars Program for medical students interested in careers in primary care for underserved communities. After earning his master's degree in education, Dr. Santana taught science and special education in the New York City public school system before he pursued a career in medicine. He graduated from Albany Medical College, completed his residency at the Institute's Beth Israel Residency Program in Urban Family Medicine, and after residency, he became faculty at our Harlem residency in family medicine, where he has served as the curriculum director for 8 years. In his role as medical director of the Care Found Here program, Dr. Santana collaborates with homeless program administration and staff and patients and provides primary care medical services, participate in educational, training, and research activities for people experiencing homelessness. Dr. Santana provides care at the Family Health Center of Harlem, the Broadway Presbyterian Church Soup Kitchen Clinic, and the Ali Fournet Center. For his outstanding work as residency faculty and director of the Primary Care Scholars Program, Dr. Santana received Mount Sinai's Institute for Medical Education's Excellence in Teaching Award in 2023. He's also a fellow of the American Academy of Family Physicians and a two-time recipient of the Gold Foundation's Leonard Tao Humanism in Medicine Award. And although it doesn't say it in his introduction, he's also a great guy. And every time we think about who we need for some really difficult kind of initiative, we always think, let's ask Victor. So, Victor, take it away. We're really looking forward to your grand rounds. Appreciate your being here.
Thank you so much, Dr. Kelman, Diane, Autumn, Eric, Dr. Schiller, everyone. It is a real pleasure to have the opportunity to speak with you today about some of the work we are doing in the Care Found Here program at the Institute, and more broadly in New York City. So today's presentation is titled Healthcare for People Experiencing Homelessness in New York City, Current Challenges, Landscapes, and Strategies. And, though not all of the providers and folks who are on the call here work in one of our Care Found Here sites, I guarantee you that you are seeing patients who are experiencing homelessness. And so I hope that everyone can take something away from this and that it's a relevant learning opportunity for everyone. And I think we go for 45 minutes and there should be time for questions. So diving right in. This is just a layout of what we're going to be talking about today. But we're going to be talking about, specifically in New York, some of the root causes for homelessness and sort of the epidemiology and scope and prevalence of homelessness in New York City. We're going to talk briefly about the Institute's program in partnership with Care Found Here. And then we're going to talk a little bit about current challenges in caring for this population in New York City and some initiatives we have going on broadly in the city in collaboration with some of our community-based organizations that we partner with, some of the initiatives that are happening through DHS, Department of Homeless Services, as well as some of the sort of special things we do with our population at the Institute. And then we'll talk a little bit about resources that we all, as providers and people who are seeing these patients and really frontline folks, resources that you can apply. And I think there are two cases that are really quick as well. And we'll talk a little bit about advocacy as well. So these are the objectives for today's presentation. We're going to discuss the root causes and scope of homelessness in the city. I hope that after the presentation, people will be able to appreciate the relationship between health and homelessness, identify and address barriers to care for people who are experiencing homelessness, and new arrivals in New York City. And so there is actually an official definition of new arrivals. So those are people who've come to our city from other nations who have arrived after March 15th, 2022, which we'll talk about in more detail later. But for anyone doing this work, and really anyone in the primary care setting, This is relevant because we are seeing so many people who just have so many unmet health needs who've arrived. We have no, information regarding their past medical history, et cetera. So we'll get into that. And then again, for providers, I hope that after the session, we all will be able to implement some primary care clinical considerations for people experiencing homelessness, right? So how do we really tailor the care we provide to meet the needs of this population? We'll talk a little bit about trauma-informed care and harm reduction approaches that we can apply in the primary care setting. And then, like I said, we're going to talk about some resources. And I think after the presentation, I'll email to Eric and Autumn some PDFs that hopefully we can share. A note about content, right? So whenever we talk about people experiencing homelessness and their experiences also in the healthcare sphere, we get into a lot of sensitive topics, right? So trauma of homelessness, the trauma of homelessness in and of itself, interpersonal violence, substance use disorders, mental illness, racism, classism, and other forms of repression. And then sort of turning the camera into how all of this impacts us as people who are frontline providers. I'll also talk a little bit about depersonalization and burnout that unfortunately is really common in people who provide care to this population. And I'm sure there are other things that are going to come up in the talk that might be triggering to people. So a note on that. You'll notice that I'm using the term people experiencing homelessness rather than the homeless or homeless people. And that's intentional, right? Because I'm trying to use person first language, which emphasizes each person's individuality, equality, and hopefully helps maintain a sense of dignity for people who are experiencing homelessness, emphasizing that first and foremost, they're people, right, who are experiencing homelessness, and that their experience of homelessness is a condition, right? It's not a personal failure. It's not a characteristic of who that person is as an individual. It's a condition they're in at this moment in time. And hopefully it serves as a reminder also that that condition can change, right? Um, but some of the terms, the terminology, and the names of the organizations use of the homeless. And so you'll see sort of sprinkled throughout the presentation a little bit of outdated language because it's just kind of hard to avoid. Um, but it's there. And I like sort of in using this language, thinking about Fanon and the ways that he taught us that, if you don't know who he was a psychiatrist and, talks a lot about decolonization. But the ways that language can potentially be revolutionary in how we think about people who are oppressed. We talk a little bit about homelessness through different ways. So one of the common ways that we speak about homelessness is about around the duration that someone has experienced homelessness. And so there's chronic, episodic, and transitional homelessness. We also talk about folks' habitation status, whether sheltered or unsheltered, and also in terms of the individual. Why is it important to make these distinctions? For one, we know that people who are experiencing chronic homelessness are far more likely than their episodically or transitionally homeless counterparts to have complex long-term health conditions like disabilities, serious mental illness, and substance use disorders, and that because of those experiences, they are less likely to obtain stable housing and are more likely to experience repeated and longer term episodes of homelessness. And so, where you are homeless and experiencing homelessness matters. Um, Chronic homelessness actually has an official definition through HUD. It's the status of being homeless for at least 1 year or on at least 4 separate occasions in the past 3 years, while experiencing a disabling condition such as physical disability, serious mental illness, or a substance use disorder. So baked into that definition is, um, information about a person's health status. There's also an official definition of unsheltered homelessness, which I'll share also from HUD. Um, a person is considered to be experiencing unsheltered homelessness if they are sleeping in a place that's not ordinarily used as a regular sleeping accommodation. And so examples of unsheltered situations would be tents, train stations, structures like shops or garages. I have a patient who rents out a storage unit and who sleeps there alongside all of his belongings, vehicles, sidewalks, etc. and essentially any location that's really unfit for human habitation. And age of the individual, I think, is self-explanatory. And so I think this also comes as no surprise that, a person generally doesn't come to experience homelessness out of nowhere, right? And I think often they find themselves in those places because of a variety of factors that all just don't turn out right. And so there are societal factors, community factors, relationship factors, who are and who were their support people. Um, it's often that folks don't have anyone who can support them. It's just that they're also struggling, right? And they just, like in New York City, don't have space to take them in. And then sort of zooming into the individual, there are, of course, individual factors, health status, mental health, etc. And so this, when I first started doing this work, people would use all of these terms that over the years I've had to just look up, frankly. And so it can really feel like an alphabet soup, right? And so I found this that I thought was incredibly helpful. And this is for the from CSH, from the Corporation for Supportive Housing. And this graphic is adapted from a publication they had that basically explains what all these terms are and something I can share afterwards, like I'd mentioned. But this just sort of goes through a timeline of sort of where someone who's experiencing homelessness might make contact with the system and the kind of housing that they might be offered or might be exposed to. And all the way on the bottom, you'll notice I put sort of other. So this includes places like nursing homes, hospitals, rehab centers, jails and prisons, warming centers, and drop-in centers, which obviously aren't meant, I guess, for the exception of jails and prisons for long-term habitation, but our patients find themselves in. Um, and Moving along, zooming into New York City in particular, this is from New York City Open Data Set and Coalition for the Homeless. And it basically shows, the census of shelter population from 2019 to 2024. I included this because it is very interesting because you'll see there in the middle, it talks about increases in new arrivals beginning in April 2022. So I mentioned earlier that I would talk about this. Um, so in April of 2022, um, it was really the beginning of a large influx of people seeking asylum and other migrant individuals coming to New York City, often bused from border states, southwestern border states such as Texas, mostly because of New York City's status as a sanctuary state. Um, and so um, that really began sort of this ongoing moment in New York City's history of large numbers of people seeking shelter. And so this figure represents the total number of people sleeping in New York City shelters on a single night in a given month from July 2019 to December 2024. And for those who don't know, all of this, like I said, is publicly available. And as you can see, the numbers of people utilizing shelter in the city has either stayed steady or increased, particularly across single adults, adults and families with children, as designated by the colors. And why did the numbers again rise so precipitously? Um, Particularly, I think, because of our status as a sanctuary city. I think a lot of it was political. Um, uh, and because DHS, Department of Homeland Security, really just in droves were sending folks by buses to New York City, also because of New York City's right to shelter. And so, for people who do not know, New York City is a city where people, adults, families, children, all have a right to shelter. This was established after a 1979 New York State Supreme Court case where New York County established that New York City has a duty to provide shelter for homeless men, women, children, and families. And so for that reason, we are seeing a very large number of new arrivals. And I think it also comes as no surprise that the majority of people who are experiencing unsheltered homelessness are people living with serious disabilities, living with serious mental illness, people with other severe health problems. And this slide sort of breaks it down by race and ethnicity. And we see that approximately 56% of households Heads of households in shelters self-identify as Black, 32% as Hispanic, 7% as white, and less than 1% as Native American, Asian American, Native Hawaiian, Pacific Islander, and 4% are unknown race or ethnicity. And I put that asterisks there because these figures, like I said, are looking at folks who are known to the system, right? And so often we'll find that in particular communities, people are doubling and tripling up couch surfing, not to save money, but because they really have no other housing options. And that's an important distinction to make. Um, and so these numbers are widely understood to be a gross underestimate of how bad the problem is. Um, and regardless of how you count it, either way, it's obvious that the issue of homelessness really is an issue of disability justice, right? Of certainly racial and economic justice, and definitely an issue of human rights, right? And then I think it's really important to take a moment right now to just sort of go back historically, and be truthful with ourselves about the tremendous impacts that generations of exclusionary housing practices, the impact they've had on Black and Brown communities from accumulating generational wealth, and then in turn, being able to own homes. So this slide talks particularly about the LGBTQIA plus community and how, unsurprisingly as well, um, both youth and adults are overrepresented in um, communities who are experiencing homelessness, right? And so 28% of LGBTQ youth are reported to have experienced homelessness at some point in their lives or housing instability. When you zoom into the sort of T in LGBT, trans and non-binary youth compared to their cisgender LGBTQ peers experience housing instability and homelessness at higher rates. And, all of the LGBT youth who experience homelessness report greater incidence of mental health issues compared to their stably housed LGBTQ peers. And then LGBTQ youth who experience homelessness also report higher rates of victimization, higher rates of being in settings such as foster care, higher rates of food insecurity when compared to their stably housed peers. So this really, I think, drives home the point that for people who are interested in doing advocacy work, that there is so much work to be done. And I think this should be obvious, but how are health and homelessness are related? Obviously you could argue that they're deeply intertwined, right? We know that medical care creates a significant financial burden for millions of Americans, and we know that more than 1 in 5 households can't afford necessary medical care. That was in 2023. And we know that when all of these millions of families have limited financial reserve, it just takes one health crisis, right, to precipitate an episode of homelessness. We also know that other problems are discrete consequences of the experience of homelessness itself, and that homelessness exacerbates and complicates the treatment of illnesses in general. And so, until an individual's health is stabilized, it's difficult to end an episode of homelessness and to work one's way out of that situation. And that when faced with a situation of having to choose between basic necessities like food, clothing, shelter, and healthcare, often the decision is to address the basic needs and healthcare comes later. And so when we look at health conditions amongst people who are experiencing homelessness in comparison to the general population, we'll see that across the board, the numbers are greater for people who are experiencing homelessness. And I think this probably comes as no surprise. What might come as a surprise is just the degree of disparity, right? Especially when we look at infectious diseases such as HIV and Hep C, and then not surprisingly, substance use disorders as well, conditions that I think often lead to these sort of deaths of despair. The next slide really talks about premature mortality. There are many different figures out there that talk about early death in this population. I found this quote from a New England Journal of Medicine article published in last year by Catherine Coe, who I think works out in Mass General, that says the mean age of death in this population is 51 years, nearly 25 years younger than that in the general population, and an age in which many Americans commonly died in 1900. And so that to me was really sobering. That referenced an article that I listed on the bottom from 2011 about premature mortality in this population. So there are different figures that are out there, but I shared this one because I thought it was particularly powerful. And then going along with that, people who are experiencing homelessness experience a disproportionate disease burden, right? So, like I was mentioning, people experiencing homelessness are 3 to 4 times higher, more likely to die than the general population. As family medicine providers, we see kids who are experiencing homelessness are at increased risk for depression, um, dental issues, poor school performance, and all these things trail and follow them, right, throughout the course of their lives. Mental illness rates are much greater. And then people of color who are experiencing homelessness, like I mentioned, during the earlier part of COVID, were more than twice as likely to die of COVID than their white counterparts. And I think it also goes without saying that the majority of people who are experiencing homelessness are people of color. So how do we get these figures? Some of you might know about the HOPE count. So HOPE stands for Homeless Outreach Population Estimate. I won't spend too much time about this, but it's basically a collaboration between a lot of city agencies, Catholic charities, where it does what we call like a point in time test, which is a survey of unsheltered individuals on a single night, usually in January, where, over 1,000 people actually will go out and try to sort of count the number of people who are on the streets and parks and other places unfit for regular habitation. And we use this data to estimate the number of people experiencing homelessness in areas that aren't surveyed. And essentially in New York City, um, and total estimate of about 4,140 individuals were experiencing homelessness on January 23rd in 2024, and that was a 2% increase from the year prior. And there are a lot of factors that can impact the accuracy of these numbers. So at that time, the weather was mild, but the week before had seen some snowfall. And so if there are factors that drive people into the shelter systems or hospitals and ERs or warming centers, it might skew the numbers. Generally, with regard to the boroughs, Queens and Staten Island saw proportional increases. And the distribution geographically of where people were staying was essentially the same as the years prior. So in case you didn't know about that, look it up. It's a very fascinating thing. And one of these days I'm going to participate in that. Zooming out nationally, in the same year, 2023, or the year prior, they'd recorded a record high number of 653,104 people experiencing homelessness. Um, and after they, broke down the numbers, they concluded that more people than ever are experiencing homelessness for the first time. So from 2019 to 2023, the people who were entering emergency shelter for the first time increased over 23%. I think a lot of that probably had to do with the pandemic as well. And then record high numbers of people were living unsheltered, especially amongst individuals. And so that also was at a record high in 2023, um, at just over 250,000. And more than 50% of people experiencing homelessness were in fact unsheltered. Again, some national data. What are the root causes, the upstream factors that, bring us to this situation? Housing costs, right? So this slide basically demonstrates that despite really meaningful progress that has been made in terms of targeting assistance to this population, particularly the unsheltered, like veterans and people experiencing chronic homelessness who are unsheltered, despite those wins, homelessness increased 7 and 1% respectively. And it's thought that the reason for this is basically the disproportionate rise in rents when compared to income, the increasing lack of affordable housing, and basically the number of people spending more than 30% of their pre-tax income going up. And the reason I pulled that figure is because that's actually the definition of what affordable housing is. So a person is in affordable housing situation when they spend less than 30% of their pre-tax income on housing. And so, in New York City particularly, 40% of us, 40% of our neighbors are rent burdened, meaning they're spending over 30% of their pre-tax income on housing, and over 20% are severely rent burdened. meaning they're spending 50% or more of their pre-tax income on housing. Um, and again, this is because of income increases that are out of step with inflation and cost of living. And then also a lot of it is policy, right? So changes historically in property tax policy have resulted in loss of more than 100,000 SRO housing units. So SRO stands for single room occupancy, where a lot of people would stay after having been unsheltered. And then going back a little bit further in time, even this process of deinstitutionalization that resulted in tens of thousands of people with serious mental illness being discharged from facilities, a lot of them upstate, into New York City. So, what is the institutionalization? I just wanted to talk about that. So, beginning the mid 20th century, mostly the 60s and 70s, a lot of Western societies embarked on a process of deinstitutionalization. And so, with that came the closure of large state-run psychiatric hospitals, previously known as asylums, right? And I think the intentions behind that were good, right? There had become a growing critique of the inhumane conditions within asylums. And there were also advancements in pharmacotherapy for this population, right? So haloperidol received FDA approval in 1967. And there was also a rise in community mental health services, right? And they were seen to be a sort of more humane and more cost-effective alternative to institutionalized care, right? But in order for this whole grand idea to work, there really needed to be a lot of communication between these institutions and most importantly, a really strong community-based backbone, right? Um, and you could argue that then and arguably even to today, that strong mental health community base and that strong degree of communication between mental health institutions and their outpatient counterparts, that strong reliance doesn't exist, right? And that gaps in care result in really diversion as opposed to sort of warm handoff, safe transfers of individuals from institutionalized settings to the community. And then when you have individuals who are not having their mental health needs met, their physical needs met, they become trans institutionalized, and I'll talk about that. And so that concept of trans institutionalization really emerged from sociological literature and discussions around mental health, social control, and institutions designed to really manage people whose lived experiences deviate from normative societal expectations, right? And so you can see from the sort of schematic, right, that people really in any of these settings aren't having their needs truly met, right? And it evolves into a situation where people are really diverted rather than stabilized. And as you can imagine, with regard to health, this really fractures their medical care and their mental health care. And you could argue exacerbates the severity of their conditions. And so you might be saying to yourself, what does this all cost? Not just in terms of like human lives and suffering, frankly, um, but also in terms of dollars, right? And so I found this fascinating. So in preparing for the talk, I was looking up like how much does it actually cost for a person to be in the ER if they're an adult, if they're a kid. And so AHRQ actually in 2021 um, released a report basically that looked at how much across the nation we're spending on treat and release ER visits, right? So these are ER visits that don't lead to hospital admission. And they found that $80.3 billion was spent on these treat and release ER visits. And that's including the general population, not just people experiencing homelessness. But when you go to look at large metropolitan areas, $42 billion was spent of that 80 billion. And when you break it down by, the number of people who had these visits, it ended up being around $440 for children and about $1,100 for folks who are 65 and above. And that just led to like a lot of additional costs and ER visits. Um, and in comparison, when you look at the cost of rent stabilized housing in New York City in the same year, the median rent for rent stabilized studio apartment was about $1,400 a month, right? Compared to potentially $1,100 for just one ER visit on one day for an individual who's 65 and above. And when you look at non-rent regulated apartments, it was about $1,800 a month. A lot of this has changed. That's old data from 2021. But then I thought, how much does it cost to keep someone in jail, right? And so this is actually information taken from the comptroller's office from 2021, Stringer. And they found that the annual cost of incarceration was about $556,000 per person per year. And when you break that down, it comes out to about $1,500 a night. And so all of this is here basically just to say, where are our priorities, right? If we spent as much money on supporting folks in the outpatient world, mental health care, primary health care, care for substance use disorders, maybe we wouldn't need to be seeing this much of wasted, in my opinion, money. And so what can be done? Um, this is where Care Found Here or Care for the Homeless and the work that we are doing at the Institute and other organizations throughout the city caring for this population, this is where we all come in. Um, and really all of those scenarios are tailored homeless healthcare organizations, right? And so these are just two studies by Cortez that show um, that when individuals who are experiencing homelessness receive medical care at clinics that particularly serve that population, they have less unfavorable experiences, and they're more satisfied with their care. And that is huge because, as we know, this population does experience a lot of mistrust, right, of um, uh, the healthcare system. And I think earning that trust can really lead to better health outcomes. This is just a map of where some of the Care Found Here sites are. This is a little bit old, um, but you'll see many of the sites where the Institute provides medical care are listed here. So the All Angels Church, previously at the George Daly House in the Lower East Side, the Senate Hotel Residence, the Broadway Presbyterian Church, the Alley Forney Center. And so historically, the Institute has sort of been the Manhattan team for the Care Found Here program. This is just like an infographic from Care Found Here that talked about sort of the scope of their impact last year. And so they had served, or actually in 2023, so they'd served 11,398 patients over 38,000 visits and had done a lot of work with regard to improving people's housing status as well. Um, one of the things that I think Care Found Here does really well is really pay attention to mental health and substance use disorders. And so, as an organization, Care Found Here offers psychiatric consultations and counseling by people who are CASAC certified. So, a lot of substance use counseling, a lot of harm reduction, a lot of one-on-one treatment groups, if that's your thing, a lot of MAT with buprenorphine, and then recovery sessions for people who are sort of on that stage of their journeys. An organization that everyone should definitely know about is the National Council for Healthcare for the Homeless, and it's a little bit old. It's from 2011. Um, have created a set of guidelines similar to sort of the United States Preventative Services Task Force that focuses specifically on people who are experiencing homelessness. And so their preventative medicine task force has come out with screening recommendations for the things you would expect, right? Like diabetes, hypertension. Um, but then it's tailored, right? So they talk about potentially increasing screening for people who are on concurrent psychotropic drugs, right? Because as we know, they can increase the risk of dyslipidemia, metabolic syndrome, hypoglycemia, etc. They talk about drug-drug interactions. So it's actually a really great document. And they talk about doing screenings for things that in the general setting, we don't necessarily do for all patients, right? So screening for IPV. They actually recommend hepatitis C screening for both unaccompanied youth and adults in healthcare for the homeless settings. The ones that say USPSTF there just mean that the recommendations from the homeless task force are unchanged from the USPSTF. TB screening based on local epi factors, same with chlamydia. But it's a really fascinating document, so you should check it out. It's all publicly available. Um, and then, because a lot of us are clinicians, right? It's important to talk about how we should tailor our care when seeing someone who's experiencing homelessness and you're sort of, in a situation where they feel they trust you enough to disclose that information, right? So much of it has to do, I think, with maintaining dignity and autonomy. And so a lot of it is patient driven, right? And a lot of it is also patient tailored, right? So when we talk about how we modify our plans of care, it really has to take into account the specifics of their lives, right? Um, we have to be mindful of potentially re-traumatizing these people in the retelling of their stories. Maybe they'll tell the same story of, some traumatic experience to the case manager, and then you, and then the social worker, and then the nurse, and their mental health clinician. So, um, just being mindful of that, being mindful of the stigma that they may carry, right? Because of their housing status. Being mindful, I think, as we know, when prescribing medications, that storage could be an issue. Refrigeration is almost certainly going to be an issue, right? And so medications like insulin, I think and I'll talk about diabetes in a minute, but we should be um, mindful when prescribing, and we really need to educate ourselves. I think a lot of us know, but like a pen of insulin can actually be out of the fridge for up to like 28 days. Um, and so hopefully that's not too much of a barrier, but what do you do with the rest of the pens in the box, right? So being creative around solutions for that. Safety and security concerns. So generally, not that we would frequently, but if you're prescribing a medication that could potentially cause sedation, um, Benadryl, um, think about how that might impact that patient's security if they're sleeping on the subway and they have all their belongings with them, right? If you're prescribing a diuretic, think about access to restrooms, and the potential for interaction with law enforcement if the patient is having to use to relieve themselves, right, in a place that's not a bathroom, and how that might impact their health. Think about access to food, right? When prescribing like any um, diabetic medication, temperature considerations I'd mentioned. And then, in primary care, I think so much of it is just slowing down, right? And I think one of the greatest resources that you can provide to your patients is slowing it down, being present, really taking the time to just listen. And if all you accomplished that day was having that patient be heard, and then slowly, you slowly earning their trust, then I would say that is a visit that was a successful visit. So like I mentioned for diabetes, because of the risk of hypoglycemia, I would say we should probably be mindful of when we prescribe short-acting insulin, if we do at all. Um, if someone is experiencing unsheltered homelessness, right, and they're keeping that pen on them, you might want to advise them to keep their pen in a part of their bag that's like not right at the surface where the sun is gonna, hit that warm bag. Um, you might want to get creative. We've done this in the past where if a pharmacy knows a patient is experiencing unsheltered homelessness, they'll dispense one pen at a time from that box and sort of label that box as that patient's supply, so that when that pen is done, they come and get the next one, and they haven't, let the rest of the pens exceed temperature stability. Again, consider hypoglycemia with people who are food insecure, and then also considering permissive hyperglycemia, right? Especially for our older adults who are experiencing homelessness, knowing that the risk of hypoglycemia, seizures, etc., is probably worse, right, than having someone be in the low 200s for a little bit until you can get their situation to change, or their situation changes and they can have more tight glycemic control. And this is just something I've thrown in here. I don't know if there's any evidence to this, but anecdotally, I'll say it's worked. I've written people doctor's notes so they could use the restroom. And, it can make all the difference in the world, especially like with regard to dignity, right? So if a patient doesn't have to experience incontinence, that can go a long way. So with regard to hypertension, um, factors to consider before prescribing, particularly diuretics, but also all antihypertensives, are like access to showers and restroom or shelters and restrooms, their ability to follow up, right? So if they can't follow up, is it really a good idea to start the ACE or the ARB? If they have, you know, bilateral renal artery stenosis, if they're not willing to really have their blood drawn, because again, you're taking into account their autonomy, right? Is it really a good idea to start one of those meds? Um, is it really a good idea to start a dehydrating medication like a diuretic if they're, not having access to water to begin with? If really there's a yes to any of those questions, um, or if there's a yes to all of the questions, then and only then really would we consider doing like a diuretic or an ARB or an ACE. But if there's a no to any of them, then generally we would consider using a calcium channel blocker. And I think for obvious reasons, we would avoid beta blockers and clonidine, given the risk of rebound. Um, this is just about safe prescribing. I think I talked about this already, but also needle safety, right? So I've had patients needles be stolen from them, right? Particularly their needles, and so just being mindful of that. And another thing is because a lot of this population does have interaction with law enforcement, keeping medications in their original bottles, right? So, they can clearly show that this is a medication that's mine, that's prescribed to me, and it's not, and it is what, hopefully they'll believe that it is what is in the bottle. A little bit about harm reduction in language. It's really important to use non-judgmental language for people with substance use disorders, and there's a lot of overlap in, that these populations. Um, and so I think this is familiar to many of us, so I'm not going to spend too much time. But I mention it because any further stigmatizing can lead to, the potential for you just not seeing that patient again. And so we really want to do our best to engage patients in care. And if that just means modifying the language we use, that's really important. A little bit more about harm reduction. Fentanyl test strips, I give these out a lot. And I would recommend that you do too, right? This on the right is a drug deactivation system that we don't provide to patients, but I've seen in shelters, which is really fascinating, right? So for people who want to safely deactivate and sort of get rid of their drugs without like flushing them down the toilet, these are available from OASAS, so the Office of Addiction Services and Supports, and you can get them, and it's a good way for people to get rid of um, uh, illicit drugs or even like prescribed medications they don't want to use. Um, cannot emphasize enough the importance of naloxone kits. I think we all know about this, so I'm not going to spend too much time. Um, one of the things that I was really pleased to see, this is a picture from our Senate, the Senate residence where we have one of our clinics. Um, the lengths they go through to really, in my opinion, destigmatize substance use. And I call this like their little harm reduction station, right? Because they have fentanyl test strips down there on the bottom. They've got a bucket of condoms. They have a really clear user guide for fentanyl test strips. And they also promote this organization called Never Use Alone, which, if you don't know about it, I would highly recommend you recommending to your patients. Um, that really is great about harm reduction and sort of tips that you can provide to patients so that they decrease the risk of unintentional overdose and death, never using alone being one of the main things. And then some educational materials on what fentanyl is. And just sort of that love and support, saying that we're here for you. I think we all know naloxone, there's a standing order as of 2022, right? So patients can get this at the pharmacy without a prescription from a provider. And so that is great. And with that, we'll go into our partnership. I'm not going to spend too much time on this, but basically, this is who we are. This is what we do. We have a long history with the Care Found Here program, a rich 30-plus year history of collaboration as frontline health providers. Like I mentioned before, we're like their Manhattan team. We have a subcontractor model where the Institute is actually a subcontractor for Care for the Homeless, which receives federal funding from the HRSA Bureau of Primary Care under Section 330H of the Public Health Services Act. So um, CFH receives federal funding as well as a lot of sort of private and public grants and contracts. Um, and what is our reach? So, as I mentioned, we partner with these 5 community organizations and operate 4 part-time clinics. One clinic is under renovation, and we're really pretty open access. Patients can receive services just like any other institute site, regardless of their ability to pay. We receive funding that covers the cost of prescriptions for many of our uninsured patients. We get labs for our uninsured. We can give them Metro cards. I say pretty open access because a couple of our sites are within shelters or permanent housing for people who are chronically homeless, and I'll get into that. So you can't just walk into the street into a shelter and go to that clinic, but you can go to one of our open access sites at the church-based sites. So the Broadway Presbyterian Soup Kitchen has a clinic, as well as the All Angels Church. Elisa Wallman, our program director, does a ton of work and is amazing, and reports back to CFH monthly. And we have a bunch of initiatives that I'll go into in a little bit. Um, like I said, these are our sites. The LA Fortnite Center is a drop-in center for homeless LGBT youth. The All Angels Church is a open access site. Same with the Broadway Presbyterian Church. At Broadway, there are also shelter beds, faith-based beds. The Senate is permanent supportive housing for formerly and chronically homeless adults, many of which have mental illness and substance use disorders, and they have 136 beds. The Valley Lodge physically is beautiful, and it's 110, it's a brand new building, 110 bed transitional housing to provide shelter, meals, services, mental health care, medical care to 110 residents. And then, a lot of these sites also do outreach. And so I'm just going to breeze through these. This is the brand new Aliforne Center site where hopefully soon we will be operating a clinic, but this is their community room. And it's a drop-in center and service center, like I said, for homeless LGBT youth. And these are the services they provide. The All Angels Church ministers to people experiencing homelessness and those in extreme poverty. They have a light breakfast, showers, a clothing closet, mail service. That's a big deal. Getting mail is so difficult if you are unstably housed or don't have an address. Um, this is the Broadway Presbyterian Church, which is one of the sites where I work. They do breakfast, lunch, and dinner for shelter residents, medical care, social work, case management, life skills, so groups, computer classes. They have a computer room. Um, and this is the Senate. And so this is, like I said, our one site that is actually not a shelter, it's not a soup kitchen, and these people are housed. And this is permanent supportive housing for formerly homeless adults. And so this, frankly, as a model, permanent supportive housing has been proven to be very successful. We see patients here who've lived at the Senate and off the streets for like 20, 30 years, patients who've been patients at the Senate um, since the 90s when our program with Care Found Here opened. And you can see here the services that they provide. And this is the Valley Lodge. This is the beautiful building I had mentioned. This is actually co-located with, on the other side of the building, permanent supportive housing. And so you've got the shelter side and the permanent supportive housing side. And so often when people are able to sort of work themselves out of needing shelter, they move over to the other side of the building. That's always a really nice thing to really celebrate with our patients. Very little bit about funding and expenses. Like I said, we receive about $800,000 of income from Care Found Here. We see patients, some of which have insurance, many don't, but we do generate some income, and then we pretty much just break even with expenses and deductions. And this is our impact, right? So the top two numbers in our small program, we've reached 910 unique individuals in 2024 and conducted 5,697 visits across all disciplines. So, social work, case management, medical, podiatry, mental health, behavioral health. We have a psychiatric nurse practitioner, and I think that's all of them. And this is just a quote from Dr. Terrence Lester, who was previously experiencing homelessness himself. The bottom numbers go through Care Found Here's 2024 numbers across all of their sites. And then just a couple more minutes on current challenges and initiatives. I would be remiss if I didn't mention the new arrivals a little bit more. We talked about the busing. We talked about, sort of the conditions in the migrant welcome centers. And briefly, these numbers shifted rapidly, but the latest figure I was able to pull up was that since April of 2022, 201,000 migrants have arrived in New York City. Um, and more than 6,500 are sort of in the city's care, either through shelter or some other known organization. And despite all that, as I think we're hearing in the news, a lot of these migrant welcome shelter centers, which were once filled, are now closing. And so just really, really briefly, I know we need time for questions. These are some of the initiatives the Care Found Here program has had throughout the course of the years in our like 30-year history at the Institute. Um, Gender affirming care, there's a policy now at the Institute that is used across the sites, right? But I don't think everyone knew that that really came out of our partnership with the Ali Forney Center, where they really pushed us. At the time, there were no providers at the Institute providing this care. And, they said to us as an organization, like, we have these patients, they need the care, they should be able to get it from you. And, so they pushed us. And so Dr. Philip Baird and Elisa has been around that whole time as well. Really worked with a number of providers and people in different disciplines to come up with that protocol. And now it's something that we do across the Institute. And I think, it's important to sort of have that history, at least organizationally, to be known. We're working currently on an aging out project where patients who age out of the Ali Forney program can be seen at some of our larger sites. And like I said, we really collaborate with legal services organizations, community-based organizations, a particular domestic worker organization for survivors of trafficking to get them T visa status. There's so many things we're able to do in the program because technically all these people meet the definitions of homelessness. Um, I promise to give you resources. I'm not going to spend too much time on this, but here are some of them. This is amazing. This is updated annually from Coalition for the Homeless, which really focuses on New York City. And so these are resources that you can just Google, but basically it's the street sheet, and it talks about food programs, soup kitchens, food pantries, shower and laundry services. What do you do after it rains if you're unsheltered, right? You need a dryer, clothing services, etc., youth services. And then there are so many opportunities for advocacy. Like I said, this is just one of them, advocating for access to public bathrooms and public spaces. And so with that, I just wanted to thank everyone from the Institute for the opportunity to speak with you today, and in particular, our small but mighty team in the Care Found Here program. None of this work is possible, obviously, without everyone's really tight collaboration. And thank you to our community-based partners, of course. And as always, right, we got to thank our patients because without them, none of us would be doing any of this work. And just for the opportunity for them to honor us with their stories. And so that went really long. I apologize. I'm more than happy to take questions. This is contact information for Elisa, who's our program director, and my own contact information. So thank you so much, and I will take questions. I'm so sorry it went long. Any
Thank you,
questions?
sir. Yeah, there's a couple of questions in the chat. Do you want to see them or do you want me to read them out to you?
I don't know how to do. Oh wait, no, there I can see them.
Can
Oh,
you
okay.
talk
So
a
it's
bit
about
about primary care providers, how primary care providers identify when a patient is experiencing homelessness?
oh, yes. Oh, how can we? Yes. So. I guess we're talking about at the general sites because generally, if they are presenting to us at one of our, Care Found Here sites, there's almost an assumption, but I think it's all just in the way that you ask, you could say, where are you sleeping? Where have you slept last night? Where are you sleeping these days? And there's no, that could be at home, that could be at my friends, that could be in the subway. Um, yeah. And so
If
just asking, but really in a non-stigmatized way.
a
Um,
patient has a family doctor at 17th Street, can they still get services from Care for the Homeless site?
Yes, absolutely they can. I will say that, for things particularly like mental health services, while we have a psychiatrist and we have technically a social worker on staff, who's amazing, and I mentioned, um, we do a lot of times, believe it or not, actually very closely collaborate with the larger sites because the volume is just it's tremendous, right? And so we do have a really small site. Yes, they can, but I would be more than happy if you would be willing to sort of run through the cases with you in particular, to find ways that we can sort of best meet the patient's needs. If it means that they, have to transfer their care to a Care Found Here site, yeah, I guess it's doable, and I'm happy to do that. But I also think there's something to be said for like everyone having that skill set because this should just be like universal, right? Our ability to have these conversations in ways that are non-stigmatizing. Um, and I know Dr. Karp, you're amazing.
Yeah.
What's so great, I think, about the Institute is that at our sites, we don't really offer anything different. We offer the same things that you all do in case management and social work at larger Institute sites, right? Um, I think, we don't get people housing in the sense that we're doing like all their housing applications, but we will refer them to the people who, can help them with that directly. Sometimes we get them housing in our Valley Lodge site.
I want to
Hopefully
ask you, I
that.
want to ask you a non-medical question. Um,
Okay.
so all of us walk up and down the streets all the time in New York, and we see people who are homeless.
Yeah.
And, you know, it's each time it sort of gives us a little tug, at our, is there anything that you can do passing somebody who you know is homeless on the street, in a 5 or 10 minute period of time? Is there any kind of resource? Is there any what questions would you ask if you had 5 minutes and you saw somebody there having this experience? Is there anything you can do to sort of add some humanity to the
Mm,
work by not just walking by them like you didn't see them?
yeah. Yeah. I guess a clarifying question would be whether or not they're in crisis. I'm assuming they're not, right? Because you're just trying to have a conversation. Because
Uh,
I think if they're in crisis, it's a whole different,
that's a whole different thing.
yeah.
Yeah.
But if not, you're just trying to be a human being to that person. It's a great question. I mean, I
Then
think
it was a hard
I,
question.
I can't, I mean, there's no right answer here, right? But like eye contact, anything to establish that you've recognized this person's humanity, you know, I think if there is an ask and you have what the ask is and you feel safe doing that, then an offer could go a long way. Um, I think slowing things down, um, goes a long way, you know, just modifying the way that you talk, presenting as non-threatening, non-authoritarian, not someone who's going to call the police on them. Um, I think there's probably going to be a degree of suspicion as to why you're approaching them if you approach them. So recognizing that they might be coming from a place of mistrust. Um, and I think that's totally reasonable given a lot of the experiences folks have had. And then I guess getting into whatever it is you wanted to talk with them about, but nicely. Um, I'm not sure that's a great answer, but I'm not sure there was a correct answer to that one. Anyway, um,
Any other questions?
Nozzle gives away
Yeah,
socks. Oh, yes.
yeah.
Oh, my
No,
goodness.
and Nikki Nairn.
Yes. She used to have concerts where she would
Yes,
collect socks and
exactly.
then there would be piles of socks. Yeah, right.
So
I
carrying
mean,
around socks.
yeah, who doesn't want a great pair of socks?
Right. Victor, I know we have very little time. Just comment a little bit on the training opportunities in this
Absolutely.
program.
Yeah,
Because
yes.
it's a great opportunity. It's just an exceptional opportunity to learn with this population.
Yeah, I mean, I think a lot of the residents know that the Ali Forney Center site is a site where people get experience and exposure with gender affirming care and also just like the language, how to be in the room with people who are experiencing homelessness and have these difficult conversations regarding their status, how to do so in a way that is kind of unlearning a lot of the stuff that we've learned how to do, right? It's not about getting through the whole checklist of the full medical history because a lot of times that could be traumatizing, not getting into the deep social history and trauma on the first visit with someone you're just meeting. But if it goes there, great and good job. But just being really mindful. But we take folks for elective rotations, the adolescent medicine rotations, for both the uptown and the downtown program, rotates with us. We haven't had an upstate resident rotate through in a while, but we'd love to have you for an elective. There's just so many training opportunities through the program.
Great.
And then one of our grads is now a fellow at Monty. So training opportunities outside of the institute. Um, the Montefiore residency in family and social medicine has a fellowship, right?
Hmm.
So I think we know Dr. Lazaris graduated maybe last year, maybe 2 years ago, is currently a fellow. I think he graduated last year.
Yeah.
And yes, Upstate can come. Just let me know. Let me know in advance, because a lot of the sites, particularly the Ali Forney site, is in high demand.
Well, I just want to say whether, to everybody, whether or not you're part of this program or you've worked in this program or you've experienced it, this is just, it's part of a family of things that we do at the Institute to sort of recognize that not everybody is in the same place and not everybody has the same issues. And it's really a privilege to have worked with you and to continue to work with you, in such an important program. And it is amazing that it's been around for 30 years. But like many of our programs, it started when the sponsor of these programs, which was some doctor at St. Vincent's, when the hospital decided just didn't want to do this anymore. And we stepped in to become a Manhattan provider for them. And it's been an amazing set of leaders at Care for the Homeless. And it's been a privilege to be a part of that program. So thank you for great grand rounds. Have a great day, everybody.
Thank you all.
Thanks, Victor.